Good evening, everyone. Can you hear me okay? Great stuff. Okay, super. So, apologies for not teaching for a few weeks. I've been skiing and on holiday and just generally enjoying myself, but I'm back now. And for anyone who is new to this and have never attended the teaching before, what I'm going to do is I'm going to go through lots and lots of cases which may appear in the Viva, may appear in the short cases, or may even appear in the long cases. And I am going to show fairly typical stuff. You will now know, of course, that in the Viva, each examiner only shows you three cases. So in that respect, the system I use is a little bit more than that, and there'll be a bit more chat in the real exam about the clinical aspects of various cases. But what I'm going to do is, in order to get through as many cases as possible, I'm going to show you lots and lots of examples of pathology. Okay, so the first case is a patient who has got stacked coins appearance to the small bowel. They've got reflux in the esophagus, and so this is a patient who's got scleroderma, and it's a typical long case or Viva case. Okay. Okay, what's going on here? Patient's got some surgical clips from an appendicitis, and what would this patient look like if you looked at them clinically? Have a think. Yeah, neurofibromatosis. So we've got lots of raised skin lesions, which you can see here and here and here. And this patient has got neurofibromatosis. This patient has suffered a head injury. So tell me what sort of injury they've got. Yeah, they've certainly got an extradural, okay, because there's the coronal suture, there's the lambdoid suture, but they've also got a subdural collection in addition to an extradural. So they've got both. And here is the fracture that is almost certainly causing disruption to a branch of the middle meningeal artery. Okay. Now the middle meningeal artery lives around here, but of course on one slice the fracture may be situated in the occiput, but quite often the fractures are very extensive and they extend into the temporal bone. But this patient has got both an extradural and a subdural hematoma. Is it okay to say epidural hematoma? Yes, it is. We all understand what that means, so that's fine. Patient with abdominal pain. Any thoughts? Yeah, pneumatosis of the small bowel and portal venous gas. Portal venous gas goes right out to the periphery because the gas is going in the same direction as the blood flow in the portal vein, whereas biliary tract gas tends to be a bit more central because although it's going towards the periphery, the direction of flow of bile is from the periphery to the centre, and so it's going against the tide, so to speak. So you get peripheral positioning of the gas with portal venous gas, and more centrally, it's going to be biliary tract gas. Okay, this is a trauma case, day naught. We've got a fracture here. We've got a fracture here. There's some blood in the pelvis. and there's a hemothorax. There's the axial view, which goes with the fractures in the ribs at this point. The next day, or sorry, 2 days later, supine film got increased opacification of the left hemithorax, and that's due to the hemothorax. And then day 3, we've got herniation of a hollow viscus, whether that be the stomach or the colon, through the defect in the diaphragm. And so whenever you see a diaphragmatic hernia, as we see here, there's the colon going through the defect. Don't forget that the injury to the diaphragm is probably going to occur at the time of the accident, and you just need to go and look back at the original CT, and you can see that there is a defect in the diaphragm at that point there and at that point there. So this patient has got a ruptured of the left hemidiaphragm. Always look back at the original images if you're not sure what's going on. Okay, what have we got here in this patient with abdomen pain? Yeah, malrotation. Yeah, well done. So malrotation, this is a complete malrotation where the jejunum is in the right side of the abdomen. But all you really need for malrotation is there's the pylorus just here, and the DJ flexure should be up here. Should be on the same level, okay? And anything that doesn't conform to this is a form of malrotation, okay? But this is really quite marked malrotation. Okay, this is an isotope renogram in an obstructed kidney, and the obstructed kidney is on the left-hand side. So the left side is this one here in red. This one here, there's the left. And this is the right in green. So let's have a look at the right kidney first. Normal uptake of tracer in the nephrons. And during the uptake, it excretes normally. So you can see normal excretion. Whereas on the right-hand side, there's accumulation of tracer, and this corresponds to what you can see with the red part of the graph, where in spite of the Lasix injection, the accumulation just carries on. And this is obstruction, okay? That's obstruction, and this is a normal state of affairs where you get excretion of tracer from the kidney following the Lasix injection. And that obstruction can be due to a stone, it can be due to PUJ obstruction, it can be due to any number of causes of obstruction. Okay, this patient is suffering from fever. They've got an abscess in the neck. And what vessel is missing on the right-hand side? Yeah, the right internal jugular is missing, and this is called Lemierre's syndrome. It's a combination of abscess in the neck with thrombosis of the left internal jugular vein. Okay, this patient has a pneumothorax. They get a chest drain put in with a good result. Patient feels better 3 hours later. and everything fine, patient's well, and then a further 5 hours later, we get consolidation in that left lung. Now, it can't be due to trauma to the lung because this X-ray did not show any evidence of consolidation around the drainage site, and this is re-expansion pulmonary edema. So it's not very common, but when it does occur, it's very characteristic. Okay, so the golden rule is if you are going to put a chest drain in for either a pneumothorax or drainage of pleural effusion, it's vitally important that in the case of pleural effusion, you take off the fluid slowly, so that there's no chance of re-expansion pulmonary edema. It's a little less controlled with a pneumothorax drain. Food debris in the stomach, small bowel dilatation, and a calcified lesion in the midline, or just to the right of the midline, which is represented by this structure here with a desmoplastic reaction. This is carcinoid syndrome. Sorry, not syndrome, carcinoid of the small bowel mesentery, leading to intermittent small bowel obstruction. Very difficult. This patient has got a stone in the left renal pelvis, and you can see gas in the collecting system of the left kidney. I'll just remove that ink so you can see it's very, very subtle, very difficult to see. But when you do the CT on this patient, you can see the gas in the calyx, and there's the stone. So this is emphysematous pyelonephritis. Now, when you get gas in the substance of the kidney, that is a worse prognostic feature. When you get gas purely in the calyces, that is, I suppose, pyelitis. And if you get gas in both the substance of the kidney and the collecting system, it's an emphysematous pyelonephritis. And the organism is usually E. coli. Okay, so it's important to recognise that this is associated with diabetes and E. coli organism. Okay, what's going on in this patient? Yeah, bilateral tubo-ovarian abscesses, one on the right, one on the left. Fairly typical. Left-sided hip pain. Yeah, there's a destructive lesion of the iliac bone, and whenever you consider a destructive lesion, always think metastases, breast, bronchus, thyroid, kidney. Okay, and don't forget myeloma and lymphoma. Okay, all of these causes will comprise 95% of the causes of this destructive lesion. So don't go talking about uncommon things like melanoma, colon, ovary, and then things that don't cause lytic metastases. Just think about those 4 metastases and then myeloma and lymphoma. And look for other lesions elsewhere when you're describing it to the examiner. Okay, this patient's got abdo pain. emphysematous cystitis, again, E. coli and diabetes are associated with this condition. The more I practice, the luckier I get. Gary Player, that's very true. Okay, what is going on here? Abdominal film. So we've got, looks like embolization clips. This looks like a TIPS, TIPSS, and that's a Seng, Stark and Blakemore tube. Okay, and so this patient's got portal hypertension, they've had varices embolized, and they've got a TIPS. Okay, and it's all told by these surgically or in the case of radiology, interventionally radiologically inserted objects, tips, clips in the varices, and then the Seng, Stark and Blakemore tube. Okay, what's the diagnosis? Osteopoikilosis. Yeah. Osteopoikilosis. Osteopoikilosis. Very classical around very large joints. It's present also in the sacrum, and it's also present in the apophysis, which is now fused in the iliac bones. Osteopoikilosis. Trauma, how do you describe that injury to the thoracolumbar spine? Yeah, it's a chance fracture. So what's happened is there's been a teardrop, there's been a disruption right through the gap here, and that's typical of a chance fracture where you've got a hyperflexion injury, you've got edema of the cord, and that's a chance fracture. That's very unstable because, of course, the anterior and posterior longitudinal ligaments have snapped in order to get that appearance. And it's called chance fracture after a orthopedic surgeon called Chance, who first described this. This patient is taking a drug which gives you a bone-in-bone appearance, and they've had osteopenia, which is why they're on the drug. Yeah, it's a bisphosphonate. Bone within a bone appearance, quite classical. Okay, what's the diagnosis here in this patient who is about 4 years of age? Yeah, it's rickets. And so what we've got here is we've got this ill-defined cortex just here. We've got widening of the growth plate, which is here. Okay, we've got metaphyseal fraying and spur formation here, and this is fairly classical of rickets. And here is another patient with a different diagnosis, and you can see here that the patient has got a zone of provisional calcification. It's a rather dense zone. There's outline of the cortex called Wimberger's sign, and then in the proximal tibia you can see this lucency called the Trummerfeld zone, and this is a patient who's got scurvy. Okay, they also get this Pelcan spur. Okay, don't forget scurvy can also give you subperiosteal hemorrhage, which can ossify, and this patient's got subperiosteal hemorrhage, which is ossified. And this patient, not only have they got the subperiosteal hemorrhage, they've got a very marked Trümmerfeld zone, which is here, and they've got this periosteal reaction, which is of course the subperiosteal hematoma, and then Wimberg sign. Okay, this patient was involved in a road traffic accident 10 years previously. You can see that there is no spleen, but there are splenonculi here, here, and there's something in the pleura above the diaphragm, and that is thoracic splenosis. Thoracic splenosis. Okay, patient has got cold, pulseless feet. There's the popliteal artery, and then the slice below, the artery has got no contrast in it whatsoever. Okay, so the artery should be here. There's no contrast in at all, and they've got an abrupt cut-off. Now, whenever you see normal-looking vessels in somebody who's got cold, pulseless feet, rather than thinking about arteriosclerosis, think about embolism from, for example, a left ventricular clot. And so look above the diaphragm, and in this particular patient they had a left ventricular thrombus. Okay, fractured rib, trauma, and we've got a laceration, which is rather wedge-shaped. So the patient has got a hemopneumothorax. Not that you can see that on these windows, but there is a small hemothorax here. They've got splenic injury and rib fractures. Okay, this patient is a smoker, but they've also got another condition that's affecting lungs. Okay, so it's a mixture of cystic lung disease and emphysema. Could be LCH, could it be anything else? What are these things here? Any thoughts? Neurofibromatosis, yeah. So there are the neurofibromata, and there's a mixture of emphysema and cystic lung disease. So the smoking has resulted in emphysema, but the patient has also got cystic lung disease by virtue of the fact that there is cystic lung disease of neurofibromatosis. Another neurofibroma there. Okay, got retroperitoneal lymphadenopathy. We've also got mesenteric lymphadenopathy, and we've got thickening of bowel wall in a patient who's got transplant kidney, and the native kidneys are small. So this is PTLD. Obese 15-year-old boy with a limp. What do you think's going on here? Yeah, SUFE. So this is slipped upper femoral epiphysis. So the gap between the epiphysis and metaphysis has increased. It's a kind of optical illusion. The other thing is that Klein's line no longer intersects the epiphysis, okay, because it's been a slip this way and backwards. Doing a frog lateral helps to accentuate the slip, but you should also do it for the other side because 20% are going to be bilateral. Okay, so do a frog leg lateral both sides. There's Klein's line, which doesn't intersect the epiphysis on the abnormal side, and it does on the normal side. Okay, what's the diagnosis here? Yeah, thyroid ophthalmopathy. So superior rectus, inferior rectus, medial rectus are completely abnormal compared to the other side. Okay, what's the diagnosis here? Not tumoral calcinosis because it's not causing a lump. It's a sheet-like calcification, which is in the subcutaneous tissue, not in the muscle. Okay, so all of this is in the subcutaneous fat, and this is calcinosis cutis of scleroderma. Destructive lesion in the jaw. This is due to malignant destruction due to a renal cell carcinoma. This is permeative. Okay, if it was a dentigerous cyst, it would be fairly well defined. But this is all irregular. Okay, we've got multiple small nodules in a central lobular distribution, some of which are coalescing to form this ground glass change. And then we've got air trapping in the secondary pulmonary lobules. And this is a case of subacute HSP. That's a good way of describing it. So there's the air trapping due to the fact that the granulomas are around the wall of the airway, and of course air goes in okay, but during expiration the walls just fill in, leaving the air trapping, and the air trapping leads to hypoxia, which leads to vasoconstriction. Okay, and that explains why the areas of air trapping don't have a vessel or a prominent vessel within them. And eventually all of these areas of central lobular nodulation will coalesce to form ground glass change. Now, in this patient who's got pulmonary edema, it describes very nicely where the secondary pulmonary lobules are, because we've got interstitial pulmonary edema, and the centre of the lobule, they're kind of all equidistant from one another. And so when you get a central lobular nodule, they tend to be equidistant from one another. They coalesce to form this ground glass change, and then you get this air trapping and very prominent air trapping, as you can see. So when you see mosaic attenuation, you've got to ask yourself the question, is this due to an airways problem or a vascular problem? and you need to do an expiratory scan, and you need to ascertain whether or not there's any air trapping. If there is, it's due to small airways disease, but if not, it's due to small vessel disease or something like chronic thromboembolic disease, okay, or a vasculitis. And in the same way, it could be due to fibrosis, fibrosis such as obliterative bronchiolitis or Swyer-James syndrome, where you've got fibrosis in the wall. Instead of the granulometer, it's fibrosis. Air goes in, but it can't come back out because the bronchus collapses. You get air trapping, and that leads to low oxygen levels, which leads to vasoconstriction. I've run out of room. There you go, vessel. So this is a case of obliterative bronchiolitis in association with bronchiectasis. You've got a small pulmonary artery on the left-hand side. This is a patient who has got extrinsic allergic alveolitis, very florid, that's inspiration, that's expiration, very florid air trapping. And in hypersensitivity pneumonitis, it's a bit similar to the fibrosis of the wall, except it's due to granulomas, and during expiration the wall collapses. So this is the best example you will ever see. I'm going to show you now. This is expiratory because the posterior wall has caved in, and all the air trapping that you can see here has been accentuated by virtue of the expiration. Yeah, and as we go further down, you can see that this air trapping has been accentuated on expiratory scans. We've even got a little bit of bronchomalacia where the posterior wall of the bronchus intermedius has caved in, and we've got this mosaic attenuation. And you can actually get this mosaic attenuation with sarcoidosis as well, because sarcoidosis, a bit like hypersensitivity pneumonitis, will give you granulomas of the bronchial wall as well as the bronchiovascular bundles. Do you need a prone scan in all these cases, or is supine enough? So that's a good question. If it's unsupervised by a radiologist, by protocol, patients who are thought to have interstitial lung disease will probably have a prone scan. But if the radiologist is there to oversee the scan, you can use your judgment as to whether or not you need a prone scan. In these cases where it's obvious that there's some abnormality, a prone scan isn't going to help. So no need to do it. Chest x-ray in a patient who 24 hours earlier was involved in a road traffic accident and they became suddenly breathless. What have we got here? Yeah, diaphragmatic rupture, and this is the stomach, which has migrated through the defect in the diaphragm, and this can occur 24 to 48 hours after the injury. Okay, so you may not see it initially soon after the accident. Okay, what have we got here? Rib notching, rib notching. What's this? Yeah, it's an aortic stent for coarctation. Coarctation, and you can just see this rib notching. here, lesser extent there. Okay, this patient has got abdo pain. Yeah, there's hiatus hernia and there's free gas. You can see both sides of the viscus, which is contained here. And there you go. And we've got the gas within the hiatal hernia. There's the falciform ligament. So it's pneumoperitoneum in a patient who just happens to have a very large hiatus hernia. Okay, this patient had an out of hospital cardiac arrest. Any thoughts? Hypoxia, day 1, day 5, day 6. We're losing the Sylvian fissure because of cerebral edema. And as the brain substance becomes of low density due to continuous anoxia, the subarachnoid-like signs start appearing. Now, it's not a subarachnoid hemorrhage, but it looks like one. But it's called the pseudo-subarachnoid sign, and that's called the pseudo-delta sign. Okay? And that can be caused by subdural hemorrhage or this phenomenon with global anoxia. So it's the pseudo-subarachnoid sign, and that is a sign of anoxia. Okay, what have we got here? Well, we've okay. And in fact, we've got perching probably on the left-hand side. Yeah, it's on the left-hand side, perching. But on the right-hand side, we've got a complete dislocation. Okay, so perching is like this, and this facet is now locked in front of the facet behind. So we've got C5-6 facet lock injury. Sorry, my writing's not great with the mouse. And that's on the right hand side. Okay, and we've got perching on the other side. Now when you do the MRI scan, there's disruption of the posterior and anterior longitudinal ligaments, and you've got disruption and expansion of the cord with edema. Okay, and then you've got disruption of the entire supraspinatus ligamentous complex. And then even following the surgical reduction, we've still got edema of the cord. And I'm going to finish there, but just to let you know, we have opened up the power course, so please visit radiologymasters.com and get yourself a place on the power course. There are some discounts available for the early people who sign up. So thanks for your attention. I hope you found that useful, and I will see you on Thursday.